Good afternoon, everyone. Welcome to the staff forum this afternoon. I just wanted to make sure that everyone can see and hear me and can see the slides online too. Just a quick few housekeeping things. If everybody could mute themselves whilst the presenters are talking, that will be great. Please feel free to type your questions on chat. We won't be live responding or monitoring them. However, they're all being captured and we'll get back to you after the session with responses. Obviously, there'll be time at the end to ask questions and we'll unmute at that point in time and give you the opportunity to ask questions. Can I request that everyone put themselves on mute before the presentation starts? Thank you very much. All right. We've got a fairly big forum today and some really interesting presentations and chats, lots of information, so we'll get on with it and at the end give you the opportunity to ask us questions that you may have. Sorry, just trying to move the slides. I'd like to begin by acknowledging the traditional owners and custodians of the land on which we are meeting and paying my respects to elders past, present and emerging.
Oh, yes.
North Metropolitan Health Service recognizes, respects and values Aboriginal cultures as we walk a new path together. Just a little bit of an overview of the presentation today. I'm going to start off by talking about a little bit of the high-level work that's happening across the system. Perhaps a bit of an overview of what is it going to look like for us when the borders open on the 5th of February, and then hand over to Professor Fraser Brims and Dr. David Spears for a little bit of a clinical overview of the planning preparedness that has been going on across Charlie's and Osborne Park. We've got Linda Cruikshank giving us some advice on what we need to do between now and the borders opening and going forward. And then we'll have the education team telling us about the range of education, training, preparedness activities that are going on, with a few requests from them on how best you could engage. So we'll get straight into it. A bit of an overview of what life is going to look like when the borders open. As you know, the Premier has announced that the borders are likely to open on the 5th of February, and we are still working to that time frame. Lots of work happening both at the system level, the Department of Health level, and at the hospital level, preparing to start seeing patients in the community and in the hospital once the borders open. So what will it look like? Most of us would have heard in the media the announcement about some sort of public health restrictions coming in once the border opens, and that increasing as we start seeing the number of cases in the community, and that would include things like mask wearing, appropriate distancing, etc. Once the borders open, we'll start seeing cases in the community. What we anticipate based on the modeling and based on the information that's coming in from the eastern states, and particularly from states which are similar to ours, is that surge or those patients starting to come into hospital will happen within the first 3 weeks of the borders opening. After that, we'll start seeing what they call is the surge, that is increasing number of admissions to the hospital with COVID, either COVID-related symptoms or patients coming for their care and incidentally having COVID as another diagnosis. It is likely, based on the experience in the eastern state, that will increase steadily over the subsequent 6 to 8 week period, after which it starts plateauing and declining. So that is what we are up for in the next 3 months, or the next 3 to 6 months or so. What will that mean for us? It will mean working differently, and I think very importantly, it will mean being flexible and agile to adapt and adopt to the cases cases coming into the hospital and the number of patients that we will have to see when the surge happens. What can we do now? What should we start doing now? Omicron is in the community. We are seeing cases every day in the media from the outbreak that is active in COVID at this point in time. Masks really important. As you know, everyone in the community is expected to wear masks. All of our visitors and staff are expected to wear masks. It's really important to start considering and implementing some of those good hygiene principles that we have very furiously worked on over the last 18 to 24 months, including appropriate distancing, hand hygiene, making sure that we don't have clutter, cleaning up, and practicing good infection control practices. We need to start doing that now if we are not already doing it, because Omicron is here and is in the WA community already, and the chances of it coming to hospitals either through our staff, visitors or patients is very real. Happening at the system level. I'm not going to talk a lot about this slide because we have it in David's presentation later when he's going to go through this in a little bit more detail. This is the WHO Health COVID-19 framework for system alert and response. It says COVID-91, that's a typo, it's COVID-19. We are still in the COVID-19 phase of the pandemic, not 91. And that's a high level structure of the framework. I'm not going to go through this in detail, but essentially it's divided into four phases: a green, amber, red, and black phase, depending upon the number of cases in the community and the volume of cases in the community. And progressively, the response increases, or the response is enhanced as we pass through those stages. Lots of policies and guidelines in progress and are coming out very rapidly and will be coming out in the next couple of weeks. So one of the really significant pieces of work that is happening at the Department of Health level is COVID care at home and the home monitoring program. This is intended to keep well COVID patients at home until the point that they are required to come to hospital. So the state has been working with an external provider, and these patients will receive advice and some telephone support to look after themselves if they do not have symptoms that warrant presentation or admission to the hospital. The public hospital visitor guidelines and guidelines for outpatient services are being updated, and we'll have the finalized version of those soon, and as is the testing guidelines. And as I mentioned, there are several other documents that are in progress and will be released very soon. Just briefly touching upon our response plan, I wanted to talk very briefly about the bed escalation plan. The really important message before I talk about the plan is that COVID will be in the hospital, and once it is in the hospital, it will be across the hospital. It's not a particular ward's problem, a particular specialties problem. It will be at some point in the outbreak, when there is extensive community transmission, it is very likely that any patient who comes to the hospital has COVID and may test positive for COVID. All of us need to be prepared to look after COVID positive patients, and all of us need to be familiar with the policies, guidelines, and the procedures that we have put in place to make sure that we are providing safe care to all our patients. So this is a bed escalation plan, because it's important to have a plan which we can refer back to. I think also important to note is that these plans are really flexible and agile and will change and will have to change at short notice. The modeling is based on the best information that is available from the eastern states and is based on mathematical numbers. What actually happens will determine how we adapt, adopt, and flex ourselves to be able to manage all patients coming through to the hospital. As you know, the 7th floor has been designated as the initial cohort ward for COVID positive patients. So it's important to have an area where we have highly skilled specialized staff and teams to look after the first COVID patients coming through the door. G71 is the designated initial COVID ward, and the original G71 ward moved to Hollywood on the 18th of January, which now gives us time to prepare G74 to start receiving COVID positive patients once we have a COVID outbreak in the community. Once we have COVID positive patients in all of G71, the plan then is to spill over into G73, which will then progressively start taking more COVID patients until it gets full. Also in that phase 2 comes ward C16, because there will be a cohort of patients who are positive with COVID, but may not necessarily be as acutely unwell and may require longer stay because of rehab requirements, because they may need to be in hospital for other reasons, not acutely unwell for COVID. It is at that point that some of these patients may be transferred over to C block, depending on the capacity of G71 to accommodate new COVID patients and acutely unwell COVID patients coming through the hospital. As I mentioned, in phase 3, we start progressively filling up ward G73. I think when we have 2 wards full of COVID, it is very safe to say that we'll have COVID across the hospital. Every ward will have COVID positive patients. The intent of cohorting is to have a designated place to manage patients who have respiratory symptoms and are likely to deteriorate because of COVID, and have that skills specifically concentrated at one place. That does not mean that other wards are not going to have COVID positive patients. Once it is out in the community, patients will test to COVID even if they are positive to COVID, even if they are asymptomatic. Once 7th floor is full and we have a large volume of patients, as is being seen in the eastern states at the moment, the plan then is to progressively think about where do we cohort our acutely unwell patients and protect a very vulnerable cohort of patients. And that means every ward, every floor and every area should be prepared or would be prepared to consider having multiple COVID positive patients on the ward. That broadly is our plan and is very much in alignment with the state plan. Really, really, really important to note that the plan will be flexible and will change depending upon how the presentations are when the borders open, and it is really hard to predict that. With that, I'm going to hand over to Professor Fraser Brims, who is our medical lead for the COVID-19 response, to talk about some of the preparedness and planning that is going on across the hospital. Over to you, Fraser.
Thank you, Ajitha. I hope everybody can hear me all right. Please signal if not.
Yes.
Okay, so on with the slides. I guess you're doing this for me, Ajitha, right there. Perfect. Now, I think we all recognise there's a fair bit of apprehension with what's going on, and I hope these sessions and some of the websites and other things will point you to, will help provide you with enough information and reassurance that you know, there's a lot of planning going on, and that we will be in a good place to deal with what's coming in the coming months. And that's certainly the idea of this talk as well. So I hope you've probably seen this little phrase or these phrases so far, but this is, you know, really important from our point of view, from a staff point of view. Ajitha's probably already said the word flexible about 6 times in her 7 slides, and that's really the key theme. We have to just adapt. It is, in a way, it's a kind of frustration, but it is also just the way it is, and we just have to accept that things will continue to change. As Ajitha said already, we need to be ready to care for patients in our clinical area. Obviously, predominantly that's inpatients. There's a lot of work with outpatients ongoing, and presumably the outpatients won't be sick enough to, well, we'll be seeing very few, I guess, COVID patients as an outpatient. And then obviously the Be Safe is about your personal protection and indeed protecting others, which we'll come back to as well. Next one, thank you. So just a bit of background I thought might be useful, just to be clear. The vast majority of people that catching or can catch COVID do so by direct droplet transmission. And that is, you know, when you're close by to them, and somebody that has COVID from their nose or mouth, the little droplets will make contact with your eyes, mouth, nose, respiratory tract, and that's how you contract it, okay? And that's the vast majority. Now, it is fair and also true to say that airborne transmission is possible, i.e. this thing can fly a bit more than a couple of meters, but the vast majority of transmission is direct person to person. And thinking back when we first dealt with patients nearly 2 years ago, we only dealt with them essentially on a droplet basis, and none of our staff contracted COVID as a result. So yes, airborne is something we will protect against, but it's not the main source of transmission. So then just a bit of talk, I guess, about just these different variants we've heard about. So because viruses reproduce so quickly, so fast, they often make mistakes in their DNA replication in their genes. And sometimes that means they just die out and they just can't sort of live any further. And occasionally, as we've seen with Delta and Omicron, it means actually they become better at transmitting and becoming more infectious, or in Delta's case, certainly becoming more of a dangerous illness. A lot's been said about Omicron, but both Delta and Omicron are still causing big problems over East. And whilst Omicron, if you look at a whole population, is or can cause milder disease, and I think David will speak about this soon, it is not always milder for each and every patient. And sadly, we're seeing over East, people are still dying of Omicron. So it's not something to think that it's okay and it's not such a problem. It might be for our patients or indeed ourselves. We just don't know. Quick recap on symptoms. These are important because not so much patients, but actually we have to think about protecting ourselves as staff. So, fever, new respiratory symptoms, that of having a cold, snotty nose, sore throat, feeling breathless, new cough, that sort of thing. Loss of smell or taste can be quite a prominent issue. About 40% of people just feel tired and worn out. And importantly, really importantly, we might have no symptoms, and that's a real concern. And that's really why we're all wearing masks at the moment, because the masks predominantly are protecting us from giving COVID to other people. That's the important part of it. And in time, there will be, policies around testing of staff and otherwise to check we're not walking around with COVID and simply not knowing about it. Next one. Okay, so some of you may or may not know, but I used to be in the Royal Navy in the past, and there's an old military phrase, which is that no plan survives first contact with the enemy. And it's absolutely true of COVID. We've already emphasized about being flexible. We had some fairly well-developed plans, thinking we're dealing with Delta, and then suddenly Omicron comes along. So we're on plan B, or is it plan C already? And as Ajitha said, we just have to be flexible for the inevitable changes that are coming. So being flexible is a really key thing. As I say, it is just how it is now. We can't, there's no point in getting kind of frustrated or wound up by it at all. Next one. So I think it's really important to have some clear terminology. So across all of North Metro and our hospitals, we're using the same terminology. So a confirmed with PCR positive patient is a red patient. An amber would be, so S could be suspected, or someone that has symptoms that could be consistent with COVID, and we're waiting to for the proper test. We'll talk about the tests in a moment, to confirm or deny. So they'd be amber. And a green would be a patients that are confirmed COVID negative. So these are important terms because, for instance, if we are requesting a chest X-ray or a CT or an ultrasound or something, radiology need to be very clear what sort of patient we're dealing with, and we need to be all using the same terminology. Thanks. So then with regard to further terminology, the tests, we've probably all heard about RATs. So this is a rapid antigen test. This is the little sort of handheld test, a bit like a pregnancy test. that we can swab, either ourselves or someone else will swab our nose, and then in about 15 to 20 minutes or so, depending on the test, you get an answer. The issue with the rat tests are, if it's positive, then you're almost certainly positive for COVID. If it's negative, you're not 100% sure that you are negative for COVID. It means that you're shedding very little virus, but you can still be in the early phases of your infection as well. There is a rapid test, which is a PCR test, which is more reliable. The problem with this is there's, I think I'm right in saying one machine, David can correct me, but there's, and the resources for that, so you can only run 2 tests at any one time. And the whole process takes probably a couple of hours to run to get a definite final answer. So yes, we can run a rapid test, but patients who require emergency and immediate treatment, we probably can't wait those 2 hours. And this is important for people needing emergency operations or emergency interventions like a stroke or a heart attack, that sort of thing. And the right departments have been practicing this and they're well aware of this, but we can't give you an instant 100% reliable test, unfortunately. And this, what I've called the standard PCR, this is the one that's been around for nearly 2 years now, as we know, sort of 9 to 12 hours or so. And that is what the majority of our patients are going to, well, almost all of our patients are going to be having, and indeed we will be having as and if we end up with symptoms or feel unwell. Thank you. Okay, so a little bit more about the plans. Ajit has kind of covered this already. So red cases, so confirmed positive cases, will go to 71 and or ICU. And initially our thought, and again could change, is that everybody will go there whilst we sort of build up our confidence and expertise with dealing with patients. Then similarly, the amber, the probable possible COVIDs will also go to 71 and be dealt as if they are positive until we know one way or the other in side rooms. But all patients coming into hospital, particularly the sort of unplanned emergency department admissions, will be tested. But they will go to their home wards and be treated as if they don't have COVID until we know the result. And this is in the structure that Ajitha just spoke about before. This is in the amber structure. This is in the sort of first phase. This is sort of February into March time, where we will be looking at what we call epidemiological risk, i.e. have they been in a household with a contact, have they had other close contacts and no symptoms compatible with COVID, or indeed, I guess, for the doctors and nurses listening at the moment, if someone has a fever, but we have a good idea where that's coming from, they have another very obvious source as to why their fever's there and no other concerns about COVID, then they're going to be just sent to the appropriate home ward to deal with whatever that primary condition is. Okay, that means at some point we will start getting incidentally found COVID patients on other wards, and this is what Ajitha was referring to. At some point there will be patients we thought were okay that just probably because they're vaccinated, they will happen to have COVID in addition to whatever it is that's brought them into hospital. And the classic one that's was around very much in the first and second waves is someone falls over and they break their ankle. They feel otherwise pretty good, but actually they're found to have COVID, and someone's coughing in the background is a good example as to what they might sound like. So those are the people, assuming they stay well, will stay on the home ward. Next one. So I guess just one thing then with the home wards, we will provide, between respiratory and infectious disease, we will provide support for those patients. We're not just leaving them there. You'll have some very clear guidelines. We'll have consults and otherwise. So we're not leaving you stranded. But this is to say they will be staying there. Now, guidelines, these are just two of many guidelines that are up and are being published at the moment. They're on the intranet, and things are changing rapidly. I'll put these two up because actually they've both changed since once we first published them about 10 days ago. Very subtle, just little wording here and there. But it's really important that when you are looking up whatever guideline it is, please go back to the intranet to look up to make sure you're looking at the latest version. It's kind of tempting at the start of all this to think, right, I'll just download everything and keep them on my desktop. but actually you could rapidly find yourself looking at something that's outdated. So be careful with that, and just again accept that the way we treat things and the way we understand how COVID works is going to keep changing in the coming months. So what can you do in the coming weeks? Well, as I've mentioned, a lot of things are going to be coming out, a lot more information becoming available. So keep track of that. Watch out for those changes, as I say, on our intranet page. And of course, WA Department of Health has a raft of information which is more state-based issues, and that will also be very useful as well. And this is a really, really, really important thing, is we all have to get better at staying away from our colleagues, quite frankly. We've in WA in the last 22 months, we had the initial wave, but from about, let's be honest, sort of July, August 20, we haven't really been social distancing properly at all. So this is ward rounds, this is handovers for nurses and doctors, this is lunch breaks, coffee breaks. We have to sit apart from each other and stand apart from each other. When we go outside, we're allowed to take our masks off, or when we sit in a cafe, we can take our masks off. But if you're closer than 1.5 meters, that means you could be giving COVID to your colleague. Okay, so we have to do things differently. And this actually, of course, is relevant for the community you know, when you're out and about rather than just being at work as well.
Thank you very much.
We all done? Okay, thank you.
Thank you very much, Fraser. I am now going to hand over to Dr. David Spears to talk about the work that Infection Prevention and Control have been doing to get us ready. David, are you online?
Yes, can you hear me okay?
Yes.
I think you need to mute, Ajitha. Thanks. All right, so I'll carry on from Fraser, and there's a lot of common themes in everything we have to say, and I'll just highlight a few of the points from an infection control point of view along the way. I'm going to start off with just a little bit about Omicron itself. So if we move to the next slide, please. So lots of talk about Omicron, lots of light and fire around this as well. And there are some truths in this, as there always is. So it is being documented well now that Omicron is more transmissible than the Delta variant. It's a bit of a misnomer to call these things variants now because they're actually the dominant strain. So in theory, they're actually wild type now, but that's just the convention of the way we talk about these things. So yes, Omicron is more transmissible than Delta. So for example, in some work from overseas, if you have a Delta case in your household, and therefore household contact is considered significant or close contact, about 1 in 5 to 1 in 10 of those contacts will then subsequently contract Delta. But Omicron, it's more infectious, if you like. So 1 in 3 to 1 in 5 of those household members will catch Omicron. So one of the first points about this is just because you're a close contact doesn't mean you're necessarily going to get Omicron each and every time. It's a risk, but it's not a given. So just bear that in mind. Because the virus is more transmissible, it is going to continue to replace Delta and any other strains that are circulating around the world. And this is just natural evolution of a virus. So a virus wants to reproduce itself because it's what we call an obligate parasite. It is totally dependent on humans to reproduce itself. So any mutations that it has that increases its ability to do that will be a selection advantage. And that's exactly what we are seeing. The other good news about virus evolution is it tends to evolve more towards milder disease because it's easier to pass on the infection from someone who's more fit and well and mingling and circulating in the community than someone who's sick in bed and not being exposed to other people very much. Of course, virus evolution started long before hospitals were ever invented, and we've created a bit of an artificial situation there. So, as Fraser said, Omicron is less severe in terms of the disease it causes, but it's not like it's a virus that really doesn't cause much trouble. There is a reduction in hospitalisation, thought to be about you have a 30% less reduction in chance of being hospitalised, and particularly a 60% reduction in actually dying with it. But as Fraser said, that still means a lot of people will be hospitalised and a lot of people will die. And you just have to look at the daily news reports over East to see how many people are dying, and they are actually dying of Omicron, almost all of them. The other thing about Omicron, which makes it harder from an infection control point of view, is because it causes less severe disease, there's a greater proportion of asymptomatic infected people. Now, asymptomatic people pass it on less efficiently, but they can still pass it on to others. So we need to be aware of that. Vaccination, the whole point of vaccination is to reduce disease severity. And so both the Omicron strain and the high level of vaccination are producing more asymptomatic cases, which does make it more difficult to control spread. And this goes back to unsuspected cases popping up in the hospital. And lastly, Omicron has been shown to evade the immune response better than the previous strains that came before it. And that follows for both vaccination and people who have been previously infected. Most people who have been previously infected have had alpha or delta, and the immunity generated from that infection works less well at protecting you from Omicron. But once many people have had Omicron in the community, then their immunity will be better if Omicron continues to circulate. So it's just a moment in time that we're in at the moment where that is an issue. And remember, the vaccines were developed from the original strains of COVID-19. So that's why they suffer the same problem. It effectively means that the immunity you have developed against, say, Delta is just less effective against Omicron. And as well as that, it tends to wane sooner than the earlier studies showed, which were using Delta. And that's why people are strongly recommending boosters, and that's why they're dropping the time period down from 6 months for the booster vaccine as well. Thanks, Ajitha. Just a little bit on testing. So you've heard about the PCR test. Now that PCR test remains the gold standard test for diagnosing COVID-19. And in WA, we have the laboratory testing, you'll be familiar, and we have quite an extensive point of care testing program going through the regions as well. You may not be aware that we regularly test all the wastewater from the city and from the regions as well for COVID as a surveillance. And as Fraser alluded to, we're about to introduce a new rapid machine to do PCR testing on people with symptoms. The one we have at the moment is for COVID and flu and RSV viruses, but the new one will cover a lot more other respiratory viruses. So that should be useful from an infection control point of view. I'll come back to rat testing because it's really the flavour of the month in testing now. I won't touch on serology because it doesn't really have a great role in hospital cases. And we still whole genome sequence all the positives in the state at the moment. And this is how we work out the clusters and the outbreaks, infections in security guards and so forth. Next slide, please. So here's a schematic of a rat test. So if you're asked to do a self test on yourself with RAT or rapid antigen testing, this is the sort of instruction sheet that you'll see. And it may on first glance look a little bit complicated, but it's actually pretty straightforward. The kits come with everything you need. They have a tube that has a bit of fluid in it called a buffer. and you swab yourself. It comes with a swab, and you swab and swirl it on both sides of your nose, and then you dunk it in this fluid in this tube. And there's various ways of swirling or squeezing the tube to get those secretions, respiratory secretions, into that fluid. You then put the 5 drops, or for some kits 3 drops, into the receptacle on what's called the cartridge, and then it flows along to where the bands are for looking for a positive or negative test. And that's called a lateral flow process, and that's why in England they call these tests lateral flow tests, for example. So that's the nuts and bolts of it. And after you've done a few, it really is quite simple. The people who struggle with this are the elderly, people with poor eyesight, and people who don't have the dexterity to manage the tubes. They find it a bit fiddly. Next slide, please. So Ajitha touched on this. The reason I've raised it here is what we have to do is take the national and state response plans and make them suitable for the hospitals that we look after as well. Next slide, please. So you saw this before, and the only reason I'm raising it here is to just reaffirm that we are in the green alert level at the moment, which is COVID ready, if you like. But upon opening of the border and the expectation of increasing community cases, we will go into the amber, which is the COVID alert zone. And this is what we're looking at for all our current guidelines and policies at the moment. And just to reiterate Fraser's point, when we move between zones, a lot of our guidelines and protocols will change with it. So just don't be caught off with downloading or printing a document because they will change. Only the electronic versions will stay live. The other point in this is, when do you go from alert zone to alert zone? And there's a number of factors that are considered here. What's going on in the community, how many cases, what strains are circulating, what the vaccination rate is like in the population, what are the tests showing. So we measure how many of our tests are positive. A sign of increasing community transmission is when the percentage positive starts to go up in our tests. And also how the hospitals are faring. So what are the numbers being admitted, how many are going to ICU, how many staff absenteeism problems are there, and so forth. So all these factors will go together to decide when you move through these zones. And moving from one zone to another is based on what readiness we have and what capacity we have, both in terms of testing and follow-up and numbers of hospital beds and so forth. So it's the capacity that drives the change, which is linked to the number of sheer cases there are in the community. Next slide, please. So you've already seen, I think, 2 or 3 traffic lights because this green, amber and red is very popular and has been adopted into a number of guidelines and so forth. So there are a number of clinical pathways and management guidelines that have already been mentioned by Ajitha and Fraser. So I'm not going to go through them. I'm just going to say that the infection control policy that you have on the homepage of the hospitals now is basically written for the green alert level, which is why I showed you that before. And we're about to release the amber alert level policy, because that changes the way we do the infection control and the follow-up in the hospital. So just be aware of that. And I'll give you some examples of how it's changing coming up now. New slide, please. So what is of great concern, of course, is how we keep both the staff and patients safe and how we maintain service delivery. So the first aspect of that is what I'm going to touch on. So when we have community transmission, what we're trying to achieve is an island of COVID freeness amongst a community of COVID transmission. And no one can guarantee that this can be 100%. It is inevitable that cases will sneak into the hospital. They will come in through patients and visitors, but also through staff. And one of the risks for entry of COVID into hospitals is often staff mixing in tea rooms and so forth, because that's when you're not wearing your PPE because you're eating and drinking and so forth. So the risks are not always where you think they are. They're not always because you're dealing with direct patient care. And we mitigate against this by screening questions and regular testing of patients coming into the hospitals, as well as day cases coming in, and in some circumstances, staff as well. We also have to control the risk once it has got into the hospital. And this is where we have the designated COVID wards to put all the COVID positive patients in a defined area in the hospital to physically remove them from the other patients. And also the need to furlough staff, which is basically sending staff home to isolate because they've been a contact of a COVID case, or they've actually contracted COVID themselves. And I'll give you an example of that shortly. And then we have to protect ourselves, not only from the cases we recognise, but also from the unrecognised cases. And these are what used to be called the universal precautions that we follow. And the obvious example of that is everyone wears masks. So you're protecting others because the mask actually reduces your chance of passing it to someone else, but it also reduces your chance of catching it if someone else is excreting the virus as well. Staff vaccination goes a long way for that protection, as does vaccination of the patients who come into the hospital. The PPE training and the fit testing program is all designed to increase that universal level of safety. And the zoning of the hospital, as I say, into patient risk zones, as mentioned by Fraser as well. And some of you may have noticed that there's some extra doors going up in different places around the hospital. Some of your access will be restricted compared to what you're used to, and that's just our way of controlling exposure of staff and patients around the hospital. And behind the scenes, you may not be aware, but there's been a lot of work done on the ventilation and airflow in the hospital. We've had occupational hygienists come in. We've had a lot of airflow measurements and so forth done. And that determines 2 rooms might look exactly the same, but based on where the air flows, one room can be high risk and one room can be low risk. And we use that in all our calculations of where we want to put the COVID pods around the hospital. And we augment that with portable HEPA filters. So up in the right-hand corner, you might see these little boxes appearing around the hospital. They clean the air and increase the air turnover to reduce the risk in the areas that they're placed. And in the bottom right is a picture of a Medi-hood, which we have on order. And these will be particularly useful for, say, moving patients around the hospital when they have to leave their COVID ward, for example. New slide, please. So here's some examples, as I say, of the changing policies as we move from green to amber. So this is the current flowchart of patients that we've been following for quite some time now. And it's the green alert, as I said, and we have these epi-risk factors. And the risks are mainly people coming in from interstate or overseas. So they're the sort of risks that we're dealing with. But that all is going to change because when there's community transmission, the risk is not going to be people coming from overseas, even though they'll still have a good chance of infection, but the risk will be from anyone who's living in the community as well. So next slide, please. So here's a preliminary look at the new way that we will do it. And there's 2 main changes here. The risks are really down to who's a close contact and who's been to an exposure site in WA. And also the building in of the antigen test up on the top left there, which you use as a preliminary screen. Now, as Fraser has said, the antigen test is not as sensitive as the PCR, but it does correlate reasonably well with the infectiousness of the person. So antigen testing people through the emergency department and people coming in for a short period of time is a nice way of excluding their infectious, even if they're COVID positive. But those who are being admitted, they have a PCR test as well. And the negative antigen test is a good sort of cover while you're waiting for that PCR test without exposing people greatly if there is someone in the incubation period of COVID. So you have a chance to then isolate them to the red zone. And I'm not going to go through the different wards, which have already been covered by Ajitha. And so using the antigen test as an extra sort of string in our bow to help patient flow and decision making, we will attempt to keep the hospital as safe as possible with these new sort of guidelines. Next, thanks. And then there is the staff. So it is inevitable that we're going to have some staff exposures going forward. So here's just I don't expect you to look through this flowchart, but it looks at the different ways you can be exposed. You can be exposed at work, which is the top category there. And when you're exposed at work, we have to assess the risk and therefore the likelihood that you've contracted COVID. And then there's follow-on testing and furloughing that will go with that. But you might be exposed in the community, but your level of exposure in the community can be quite different. If someone in the household comes up positive, then that's a high risk. But if you've just happened to have been in a shopping centre when a case was by, you may have had no significant contact with them at all, so that may well be classed as a low risk. So this is how we will work to decide what we do with staff that have been in contact with COVID. Next slide, thanks. So once you've decided what the risk is, you use charts like this to determine how we class them as to it's been a low risk exposure, it's been a moderate risk, or it's been a high risk. And, you know, in a room without good PPE, where aerosol generating procedures, as you could well imagine, would be a high risk scenario. But transient contact, passing through an area without any close contact with a case would be low risk. Next slide, thanks. And based on that, if you're low risk, you will continue at work and just be asked to watch for symptoms to develop. And if you develop symptoms, you go off and get a test. At the other end of the scale, with a high risk exposure, you'll undergo tests and there'll be a need to keep you home for 6 days or so. And that's because the incubation period of Omicron is a bit shorter, and most people will present within that 5 to 6 day period. After that, it's still possible you could present, but it becomes less and less likely. So the old days of being off work for 14 days and so forth won't work going forward, because it'll mean too many staff are away. So we'll work on ways to get people back to work sooner, but then regularly test them, something like a daily antigen test, for instance, to make sure they stay safe. They won't be able to sit in tea rooms with other people, and they may well be wearing N95 masks and so forth going forward. So just examples of how we can manage that to reduce our absenteeism. Next slide, please. And just to finish, this has only come out yesterday, but this is an example, and once again, I don't expect you to read it, of when you've moved into that alert level red and black, where everything simplifies down, all the follow-up testing becomes a rat, because you'd expect the PCR testing service to be overwhelmed, and it simplifies down to just low or high risk and so forth, and managed accordingly with a lot shorter furlough if it's needed for service. So critical services will be important, and we'll have to be flexible, as has been mentioned before, to ensure that we can maintain these essential services but keep everyone safe. So it'll be a balance of how long they can be off, whether they can be redeployed, and what testing we do on them going forward. So that's just a brief overview of the sort of infection control practical aspects that we will be following to try and achieve the goals to minimise the impact of COVID as we start to see community transmission. Thanks very much.
Thank you, David. Now going to hand over to Linda to talk about where we are at now and what to expect.
Hi, everyone. Sorry. Where are we now? So we're in a good position now. We have 100% of our staff are double vaccinated, soon to be triple vaccinated by the end of this month, or when vaccination boosters are due for everyone. We've got good compliance for N95 respirator fit testing in our high risk areas, and we've got our fit testers rolling out the N95 fit testing for all clinical areas at the moment. PPE training is something that we need to keep going. We need to be refreshing, and Anne and her team will talk to that in a moment, but that is something as a priority for all staff. We're training PPE spotters, and again, Anne will talk to that. We've got 150 HEPA filters arriving. They'll soon to be delivered, and we are hoping to maybe source some more if we can. And as David mentioned, the McMonty hoods hopefully here at the end of the month. So what to expect? So in the initial phases, things will probably travel on a little bit as normal, but as we start to get community transmission, as we start to get patients in the hospital, our environment is going to change. So wards and thoroughfares are going to be blocked off. Wards will be locked down to become COVID wards, and access will be restricted to people wearing PPE. The same is happening in the ICU. Half of their ICU will, when it's required, be blocked off for visitors and for visiting teams. And the emergency department, we've already seen they've got lots of infrastructure work going on, and that zoning's changing as we speak. Our work environments are going to be different. We're going to have to be very stringent about our physical environment and physical distancing. We've got to limit staff members in public spaces, and I think particularly tea rooms, when we're taking our masks off in front of each other, is going to be one of our high risk areas. So we've got to be get used to cleaning up after ourselves. So if you put your mask down on the desk, you may need to make sure, or on the tea room table, make sure that areas are wiped over. Shared computers, phones, desktops, and computer mouse are cleaned. And so what can I do? So at the moment, we need to up our training for PPE, make sure that everyone is looking and updating on the COVID safe on the COVID page. But what we need to think about when we do have community transmission, and it is in our workforce and in our hospital, that we are going to anticipate having staff shortages. So we've got to prepare to work differently. So looking at how we can work within a team, how we work within each other. These are going to be changing situations. I think we've seen what's happening over East, and we know now that we need to start thinking about how we are going to work in those difficult environments. We need to expect change. As I said, everything's changing on a daily basis. The information that we're getting from interstate is changing very rapidly. And we need to be prepared for COVID patients to be throughout the hospital. We may have our zoned wards and zoned areas, but we've got to consider that all patient transfers through the hospital are potentially high risk and are potentially COVID patients. So just need to be very aware of our environment.
Thanks, Linda. Over to Anne next to talk about education and training.
Thanks, Ajitha. We're focusing training in 3 key areas, all things PPE. We're developing a COVID education resource library and simulation. In terms of PPE training, we've got a number of access ways that staff can attend PPE training. We have drop-in sessions, and those dates are on HealthPoint. We're going up to 3 drop-in sessions a week for staff, including at Osborne Park. Going forward, we've also got the opportunity for on-demand sessions. So if your team as a whole can't get to a drop-in date, then on HealthPoint it shows you how you can, in the PPE training calendar, how you can book a session for your staff. And if we're available, we'll come and do it in your area. We just need PowerPoint. We're also looking at how we can offer PPE training for night staff. So in order for all staff, so PPE training will become necessary for all staff. In order for staff to get onto Lattice as having attended, you need to attend a live session, so either on MS Teams or face-to-face. But we are recording the PPE training session, and that will be up on HealthPoint by the end of this week. But that won't get you onto Lattice. You'll need to book into an actual session. We're also running PPE spotter training. This is an hour-and-a-half training session for those who may have capacity to reprioritize their role and do a couple of hours spotting, which is basically out on the floor, observing, guiding, supporting staff who are donning and doffing, and making sure that there are no breaches, or if breaches occur, that the spotters can spot them and then report those to minimize the risk of any transmission. So we'll put that into the COVID Buzz. There's a QR code, and you just need to click on it and you'll get more information. So that code will be in the Buzz every week. We're also developing a COVID library. So we've got a lot of resources that we'll be continually putting into the library, and it will be hosted on MS Teams. So it is a channel that all staff across the group are now enrolled in that channel. And when we go live tomorrow with the library, you'll get a notification that you now have access to the library. So in your local areas, you can look at the library and decide yourselves which education resources are suitable for your staff in your area, and you can access them there. We're also currently doing clinical scenario testing. So you may see a patient on a bed with a group of people around them moving through the hospital and with fluoro jackets. That's us going around testing systems and processes and our PPE practices in a simulated way to check our readiness. We will also do some incidental in situ sims in ward areas. So if you want us to work through, for example, a patient in your ward becomes a coincidental COVID positive patient, we can do that sim with you in your local area and support your readiness for that scenario. And with Linda, we'll also be going around all the clinical areas, working through what's called a COVID readiness checklist, just supporting you and guiding you to see that you're as ready as you can be, and is there any more we can do to support you.
Thanks very much, Anne.
Thank you.
Final point from me. We are heading into some really, really busy times. It's going to be different. There's going to be lots of change, and it's going to be busy. We are going to learn to live and work in a very different environment, and we will need to do that within a very short period of time. It's really important that we look after ourselves and our colleagues and reach out to colleagues who are particularly distressed or finding it difficult to cope with the changing circumstances. We have a lot of resources on the hub. Make sure that you have access to those, and encourage your colleagues to access those as required. The North Metro OSH team is recruiting COVID wellbeing psychologists, so they'll be on board soon to assist us, to support us whilst we go through this really, really busy period. Can't emphasize how important fit testing and PPE training is. We probably are talking about it amongst us the 6th or the 7th time, but really important to make sure that you are well equipped and well prepared to look after patients and look after ourselves and our colleagues. There's a dashboard coming out soon, and your managers will be in touch to provide you with information on how to access those. Final message, let's all be ready to be safe, to be flexible, to be able to manage, to care for our patients safely over the next few months. Thank you very much for your time. I see there are lots of questions on the chat. We've got someone recording them on the background, and we'll aim to provide responses to them very shortly. We probably have time for a couple of quick questions. If anybody wanted to ask a question, either of Fraser, Linda, David, or Anne. We've got a hand up, Kath.
Hello, hello everyone. It's Mari here. I'm with Kath. Ajita, sorry to bother. Just on behalf of a couple of staff who couldn't log on to Teams today, I just had a few questions. But number one, just from the presentation, was in relation to the amber and orange, and I see somebody from radiology has already asked. I know in ED we're using orange all the time. We don't talk about amber at all. So I'm just clarifying the amber orange. That's
the $60 million question. I'm Team Amber, but I do believe orange is going to be the universally accepted colour for amber. Orange.
Okay,
Same
thank
thing.
you.
Sorry, we'll amend all documents for it.
No, that's fine. Thank you. Yeah. That's great. Just wondering, with the pending time coming in February, some managers are asking, will staff who have taken very long batches of long service leave, will anyone be called back from leave? That was one question from the big batches of leave.
So I think at this point in time, we are not, there's no intention to mass cancel leave. However, as I said, it evolves very quickly once COVID comes into the community. I think it is very safe to assume that there will be very limited ability to grant leave over the next few months. So planning and preparing for that and considering extenuating circumstances for granting leave will be important at this point in time.
Okay. And should staff be splitting into different teams now within departments? Should they be working together to say team A, team B and things like that?
Fraser, can I get you to answer that? A bit of a scientific response.
Yes. Well, not necessarily, but I think, everybody needs to be keeping themselves apart from each other. But we've absolutely, same respiratory, we've absolutely been thinking that who can cover who, and importantly also, what would our skeleton bare essential service look like in outpatients, with the assumption that at some point many of us will be called onto the wards, and indeed many people may either have COVID or be a close contact with COVID and be off for a while. So I think those sorts of plannings are absolutely really, really important to start thinking about.
We haven't focused this time much on the team A, team B model, because what is seen in the eastern states is that once it comes in, it'll, a significant number of staff will get infected too, and we may not necessarily have that capacity to split staff, reduce the number of people on site, etc. So I think the message there is to be prepared from day one. As I initially mentioned, there is going to be a short period of a few weeks after which it comes in that we will start seeing the surge, staff being furloughed, etc. So good use of PPE, fit testing and infection control practices would be the ideal.
Thank you very much.
Thank you all very much for time. Thank you all very much for your time. Sorry, I've got one more hand up, probably time for a last question. But if you put your questions in through chat, we'll make sure that we get back to you.
Sorry, Ajitha. It's Sarah. Sarah Haddock,
Yes.
after CNS.
Yes.
If staff are furloughed, what pay will they get? Will it come out of their own personal leave, or will there be a COVID funding as in 2020?
If staff are furloughed, they would be paid COVID leave. Obviously, if staff are COVID positive, it will be personal leave.
Right. Okay. Okay. Thank you.
Thank you all very much for your time, and thanks for working with the COVID team to make sure that we are prepared. We have considered the policies, guidelines, and plans in our respective areas. We'll see you again soon.